So to start off, Chris, in one of our previous conversations, you said that over the last 40 years of our healthcare system has become entrenched and that Canadians want change, but without any risks. What do you mean by that?
So if you look at the front lines of healthcare and what's happened in my career over the last 40 odd years, there's been enormous change in the frontline care. Take one example, take care for stroke. If you look at some of the research that's been sponsored through the University of Calgary on stroke, you'll find that there's world-leading research and world-leading and practice-changing approaches to stroke care. And that's happened here. So front lines have had a lot of change. When I was a medical student, there was a book published by the federal government, by a federal minister of health. It was called New Perspectives on the Health of Canadians, 1975. 1975, it talked about things like there's too much acute care. There's going to be a senior tsunami. We can't afford not to invest in things like wellness, and so on. 1975. So if you look at the priorities that were set by the federal government in 1975, you have to ask yourself, why were these things not carried out? That New Perspectives on the Health of Canadians book was actually used worldwide. It became the basis of the Ottawa Charter. It was picked up by health systems around the world. Canadians thought of these ideas. They didn't enact these ideas. So you have to ask yourself, why is the structure of healthcare not changing? Or the processes of healthcare not changing at the same rate that things are changing at the front line? And it's a pretty fundamental question. I think we, as voters, we all have to look ourselves in the mirror. We've been, as boomers, very satisfied with the status quo. We haven't changed this healthcare system. Providers, public, stakeholders, everyone wants the same thing, stability. We want Canada's healthcare system to improve. We don't want to have this chart which says Canada's healthcare system is declining. When I was a medical student in 1975, we were probably number 1 or 2 in the world. We are no longer number 1 or 2. This shows it. We have to do something more risk-accepting in healthcare to produce the changes that are required. And the roadmap is out there. We've had, I have no idea how many reports, Romano, Mazankowski, Kirby, you name it. We know what needs to happen. We just don't act. And that inability to act is what is causing this gradual decline into mediocrity in this healthcare system. And as you can tell, I'm pretty passionate about this. So I think I'll turn it back to Lauren.
Okay. Well, I want to ask Jack, what are your thoughts on this?
Well, you know, it's very interesting. When we first started the panel discussion, and of course it was supposed to be on innovation in healthcare, we quickly came to the view that the issue is not innovation itself. In fact, we have a pretty good medical establishment that can do very good research and has the capability of finding lots of new things to do. The problem on the innovation side is a different part of the innovation question, which is how you organize things and get things done. And there the Canadian healthcare system has been, as Chris has pointed out, it's been declining over the past number of years. In fact, at one point in the report, we were going to put in the statement that if it continues any further, we'll be below United States, not just above United States, in the Commonwealth Fund rankings, where we're 10 and now they're 11 out of 11 countries. And so we came to the view, after a lot of consultations across the country, went, talked to all the different provinces, met with all sorts of groups and everything else, that actually there's a lot of exciting things that are happening in the Canadian healthcare system. There's pockets of very good innovation, very good work that's being done, and really moving ahead on a number of scales, fronts. But there's a serious issue of scaling and spreading. We don't scale up and we don't spread. Even within a province, we don't spread. And to give a good example, report after report in the past number of years have recommended primary care, and we can go into that a little bit more. But primary care is a step towards improved integration in our system and improved incentives that could be done in order to bring together different ways of delivering good health care to people, which includes a whole bunch of things, whether it's combining what we do in terms of home care and long-term care and drugs with the other services that are provided that are supported 100% by the Medicare system, to including things like health promotion, et cetera. And we don't do that because we don't have a very good system that allows for integration. Now, this is all known but we just can't seem to get out of our rut. And there isn't much change that has occurred over the past number of years, except for continually falling behind what other countries are doing. And if you take one country that has gone from the bottom of the Commonwealth Fund ranking to the top, and that's the United Kingdom. They have had tremendous amount of success. Why? Because they have been able to reform the system to make it patient-centered care and to improve integration of all the different services. Part of the reason for that is that the UK years ago established the concept of primary care at a very early stage in the national health system. In fact, when I was a student in the United Kingdom, my wife and I went to the gatekeeper in the system, who was our doctor. And of course, any services that you needed, you would be recommended or given to that to wherever, whatever services that you needed. So the UK actually historically has had this gatekeeper system for a long time, which we called primary care, but they were able to evolve that into much more focus on patient-centered care and other things. And in fact, one of the best days that we had as a panel is bringing together a number of experts from different parts of the world, including Australia, Denmark, United Kingdom, United States. But I must say the group that really impressed us the most was Kaiser Permanente in the United States. It has millions of members in it, but they have a holistic approach for patient-centered care, and as a result, they have a much more integrative approach as well in working with individuals. And it's kind of, we know how to do these things, even electronic medical records. You know, this has been 15 years in Denmark, and we still aren't even there yet. And so there's a real serious problem in getting the system to move forward in this country. And actually that was really what our report tried to do, is to try to put some building blocks to try to get funding from the federal government to help build or create real innovative change in the healthcare system. And we can probably get more into that later. But I think we really do need to change the modus operandi right now for healthcare in Canada.
Yeah, let me pick up on a few things that Jack has said. Pilots. Monique Béjean, when she was health minister, said Canada is a nation of pilot projects, and nothing ever gets spread out.
Yeah, we heard that a lot, by the way.
I'm sure you did, and it's true in Alberta. When we did the joint arthroplasty project, which is a provincial project that was led by Cy Frank and some other orthopedic surgeons, basically about standardizing orthopedic care. I was leading under Jack Davis, the Calgary Health Region at that point in time, and we thought this was a really great thing. We tried to get it to work, and we went to the other health regions, the health authorities in Alberta, and so they said, let's pick this up, let's move this out. We should make this province-wide. Well, there were some health authorities that said, this just won't work in our health authority. We don't need this degree of standardization. Or our physicians don't like this. Or it's too costly and it's not our priority. So even within a province, the scale and spread part was not working. And nationally, it's much worse. What we have done in the boomer generation is maximize the effectiveness of some of the silos, like acute care, as silos. And we haven't looked across as systems. So we've got silos, we haven't worked on the system. So I have a friend who had a neurologic injury about a month ago, and he's had excellent acute care. He was ready to be discharged from the acute care hospital, and he needed neuro rehab. And while he stayed in-house, he would get the neuro rehab. He was told if he was to leave hospital, he would have to go on a waiting list for neuro rehab. Like, what is that all about? You know, how can you have a healthcare system that is so ill patient-centric? And it's of interest to me that the first, thing in your report, Jack, in the Naylor report, was about making patients more the center of the system, because that's the way of keeping it honest. It's not a financial or accounting system or anything. It's a way of keeping the system honest. This system actually improved the health of Canadians. One thing about the UK that Jack mentioned, they've been willing to experiment big scale. They've been willing to experiment on different funding models, on markets, on building leadership programs, on having national quality programs. If you look, they get things wrong, but they keep moving. And within the NHS, what it's done is create an atmosphere where you can experiment, where things are willing to be taken on with a risk of failure. And what I find here in Canada and in Alberta, there's a profound risk of fear of failure. People don't want to risk because someone will be punished. People will not experiment. Experimentation is bad. And you look at the systems that are really good in the world, they experiment all the time. Any business will experiment. But healthcare is so cautious on experimenting away from the front lines. Front lines, as I mentioned with stroke care, as an example, great things happen. Get further from the front lines, the less change is tolerated, the less the risk of failure.
Well, there's really a problem of cultural change that's required, and that's what makes it so difficult, because changing culture is very difficult, is a real problem. And you know, we could talk about maybe ways of getting that cultural change occurring, but I think one of the problems that we've created in Canada is the way that we actually set up the Medicare system in the first place. If you look at the European systems with their parallel systems, one of the key things is that in the public system, all the services are being publicly supported, going from you know, hospitals and physicians all the way to dental care. You know, if you're using the public system, you can get everything, including long-term care, community care, and what we've done in Canada is that we bifurcated the system. We have Medicare support for hospitals and physicians, but not for other things that people have to pay out of their pocket or maybe government partly cover. And as a result, we don't have the systems created to even integrate that part of the system. So that's why it's very difficult, where you get people in hospitals, but then we're not creating the other alternatives that could be done, because it's not been conventionally part of the overall system. So we've created that from the beginning, and that's one of the things that, in my view, needs to change. But it's not the only thing. We've now created a culture of silos in the healthcare system. And the question is, how do you get over that? And I think that's where I think the real difficult question is that we should get into, because in my view, the change has to be kind of almost created through crisis if you want to get cultural change.
Okay. There's been an underlying theme in the report, and I think sometimes maybe the elephant in the conversation, and that is, should we be going to a system where there's private and there is public? Is there room for that in our system?
Well, personally, I think we already have a private system in Canada. In fact, 70% of healthcare costs are covered by governments, and 30% by people out of their pockets. If you go to Europe, even with their parallel systems, including private hospitals and private doctors, et cetera, governments still cover 80% of the cost of healthcare, and only 20% is paid by individuals out of their pocket. And yet, when you look at this card, you'll see the European countries are very much on the top of the heap in terms of the quality of care and everything else that they do. So obviously, the system has kind of worked better in that way. And I think that's part of the difficulty we have here in Canada, is that we have not, kind of made sure that we can get the kind of change and robust change always going. The other problem facing Canada, which is really quite different than Australia as an example, is that in Canada, the provinces are constitutionally responsible for healthcare, and they very much guard their role in healthcare, their administrative role in healthcare. And they do not they like money from the federal government, but they don't like any control from the federal government, particularly Quebec, but it's not the only province to feel that way. And as a result, when you compare us to Australia, you have a much stronger central government in these issues. And in fact, one of the things that came up when we had the panel, when the Australians spoke, they have gone to activity-based funding for hospitals. And in fact, they price hospital services. We don't. I mean, in fact, our budgeting in hospitals, probably Chris, you can say a lot more about this than I can as an expert, but I know that the budgeting for hospitals in Canada is not very well done. It's certainly not activity-based. You have no idea what the cost of an operation is or anything like that. But in Australia, they do. So we asked the Australian expert, how did Australia able to get the state governments to agree to activity-based funding? And he said, well, we told them they had to do it, or else they wouldn't get the money. Well, if you try to do that in Canada, you won't get much success, because the federal government doesn't have as much strength in this issue, constitutional strength, as in Australia. And the same thing in England or in Great Britain, where you have a very strong central government that can, require reform through the whole system. But that still doesn't prevent provinces, especially the larger provinces in Canada, from making change. And when you look at Alberta and you look at Ontario, you have to ask the question, like, why aren't they making big changes? Why aren't they doing reform right through the whole provincial system, such as things like primary care, patient-centered care, things like that? And there's no reason, there's nothing preventing, especially the larger provinces that have the resources from doing this.
So I think the public-private thing has been used politically not to the benefit of the healthcare system. I think the fundamental question is really, where does competition lie in this healthcare system? How do you compete? Any business gets better by competition. And as a former leader of Alberta Health Services, it's very hard to see where that competitive environment was in health. We had it a little while. There was a hospital here called the Health Resources Center down on 14th Street. And they were doing basically hip replacement, knee replacement under contract to the health region. And that actually was very instrumental in looking at healthcare in a different way. It forced the system to pivot a little bit, because there were people who were looking at how you would deliver this care in a more private sector oriented way, in a more efficient way. And because of that activity, I could use metrics and go back to the publicly funded system and say, these guys are doing this. Why aren't we doing this? And the argument comes back, well, we're dealing with the sicker patients, okay? And then you stratify and say, well, sicker patients or not, you're still not performing as well. But that sort of ability to have some degree of competition seems to be absolutely invisible from the Canadian healthcare system. The other thing is that we pay for activity. We don't pay for outcome. And if you look at the accountable care system in the United States, you're basically paying for outcomes. You want this many hip operations done to this quality. This is the money. I don't care if you have complications. I don't care if the sky is falling. That's how much you're getting. And it forces people to rationalize the way they do resources. We've had in Alberta on the activity-based costing front a couple of things on that. In the late 80s, early 90s, at Foothills Hospital, you could do activity-based costing. We had an electronic health record. We could drive down total procedural costs. And as we went through structural reform, that was lost. And what I've noticed, every time you go through structural reform, some of the best things are lost. We had Stephen Duckett here. Stephen Duckett, when he was CEO of Alberta Health Services, was trying really hard to bring in activity-based costing because that was his academic forte. And again, more restructuring, people change, that was lost. But activity-based costing is entirely possible, and it's part of the mechanism at the toolkit you need to have competitive environment in the healthcare system, but we don't do it.
Chris raises a very important point, and that's about yardstick competition. And one of the things that a parallel private system can do is provide, a different way of doing things, innovative ideas that actually could help the public system as well in its cultural change that it needs. But there's also a need, even within the public system, for more competitive type forces. And I'll give you an example, and I'm sorry to raise this at breakfast time, but when I needed to get a colonoscopy the first time in Ontario, it took me 3 months on a waiting list to get it. When I came here to Alberta and I was due for another one because I had a grandmother that had colon cancer, so it was a bit of a risk in that sense. But when I came here to Alberta, I was told it was a 3-year waiting list. I said, that's ridiculous. Why is it so long? They said, well, the hospitals are given a monopoly. Only they can perform the colonoscopies. Well, in Ontario, what actually you see is there's a whole bunch of clinics that are outside the hospital system that are able to do colonoscopies. In fact, I went to the Rudd Clinic in Toronto. This is a small example, but I can give you other examples. Here in Alberta particularly, there's a lot of monopolies in the system. In fact, there's a need to introduce more competitive forces within the public system of different types of suppliers and take it out of the hands of the hospitals where they are given monopolies. And Chris, you can probably talk about this more than I can, but I know that some surgeons and people who come here to Alberta, with their spouses, have not been able to get operating time. Why? Because existing doctors get control over the times in terms of hospital operations and surgery time. And so it's very hard for someone new to come into the system, even though they were very good, well-practicing doctors that were in Ontario or Quebec doing the same thing. And so this, you kind of wonder, like, what are we trying to do in this? Why do we try to protect monopolies in this way? And one of the things that I know in talking to the Deputy Minister in Ontario, Finance at that time, he told me one of the things that we're trying to do in healthcare reform in Ontario over the past number of years is try to break down the monopolies. And in fact, that's one argument really for a parallel system. That helps further competition and breaks down some of the monopolies in the system.
What Jack is alluding to is the power of stakeholders in the system. The combined power of UNA and the AMA to stop any further evolution of healthcare delivery that would affect their entitlement to income is huge. The physicians don't have a lot of power to say yes to things, but they have incredible power to say no. And they can basically stop any reform maneuver in its tracks by their ability to say, we don't support that, work through various political, channels that are available to people who can invest in political parties. And it really has become a system about the power of stakeholders. There's an article in the New England Journal a few years ago looking at where the increases in healthcare funding had gone in Canada when increases had come along. And most of it had gone into the pockets of healthcare workers, not in terms of them working harder, but getting paid more. So roughly 70% of every new dollar goes into salary escalation or fee escalation of people who are working in the system. So it's a very provider-centric system. And so, there's a lot of talk about this becoming a more patient system. I just have no idea how that mechanism works. Like, how do you actually get there when stakeholders control so much about what happens in the healthcare system? And, there are various ways that the physicians and the nurses act as a cabal. And if you're a young person in either profession, your chances of getting the right shift, the right availability to OR time is questionable. It's a very tough world out there for new practitioners coming in, no matter what the profession is.
And in fact, one of the things I think it's one of the things that governments need to do is to try to force reform through consultations and everything else. But the last thing they should do is keep throwing money into the system, because what that does is takes away any incentive to reform. And in fact, probably one of the better things that the Harper government did was to say, okay, here's what the provinces get, an escalation of 6%, then it's going to be GDP thereafter. Actually, healthcare costs have been rising less quickly than the 6% in the past several years, so actually the provinces have made a little bit of money on that. But that's not the point. The point is that if the federal government just started giving the provinces more money, and the provinces then just throws more money into the sector, nothing will change. And in fact, that's what's been going on. I think the Martin reform didn't do anything to really improve the system, except they did have some conditions. And so what happened is that we did see waiting times decline in certain procedures, but waiting times went up in other areas, because what do you expect? People are going to say, well, we're going to reduce waiting times for hip replacements and et cetera, but then at the same time, we're going to take resources away from other things, and so what happens, waiting times go up. So we've had, right now, that's why I think one of the things that we need to get is the governments themselves willing to take the horn of the bull and try to redirect it in some way. But the last thing is throwing more money into the system without any required change, because it's going to get eaten up by salaries.
Yeah. And there's a big difference between reform and restructuring. Alberta has championed Canada in terms of healthcare restructuring, and it's very difficult as CEO of Alberta Health Services to look at the performance of Alberta compared to Ontario, where there had been essentially no change in the delivery system for 20 years, and Alberta had literally, eaten itself alive with the various changes that occurred, going from hospitals to health authorities, going to health authorities to Alberta Health Services. All of the creative effort of, basically a generation of people went into restructuring, not into reforming. So if you're going to reform a system, if you're going to restructure for a system, it has to be for a purpose. And the purpose cannot be that, we'll try it for 10 years and then we'll throw it out and try something else. That there's just no capability to have a system put in place achieve excellent results and have that measured in 10 years. Restructuring is a long-term thing, but it has to be done in a way that actually supports some principles, whether it's competition, whether it's having care not in silos, but that follows the needs of patients. Whatever you do in terms of restructuring has to be more purposeful than what has happened to date.
Well, I think the mistake was that actually the purpose was to try to save costs. In fact, I've seen this with municipal...
How did that work for you, Jack?
and I've seen this with municipal amalgamations, and I've seen this with Alberta Health Services creating this big entity. But from economists will always point out, but there isn't always administrative cost savings that people keep harping on because they think you can get more economies of scale when you get into larger organizations. Economists will also talk about diseconomies of scale. That sometimes when you get too big, you end up getting coordination costs, and you get building bureaucracies and things like that. And so there's not necessarily a lot of value to actually having these large amalgamations, plus you become less sensitive to the different types of populations that you may be trying to service that may be important from a geographical sense. And so, I think these restructuring efforts have been based on the wrong objective, in a sense, is what you're saying, Chris, because what we should be doing is sitting back and saying, okay, what is the fundamental need that we have today? And I would argue it's patient-centered care. I think we need to get focused on that. In fact, that's really what we talked about in the Naylor report. But to do that is the question, how do you get there? And what are the things that the governments need to do? And maybe that's really more for our discussion right now.
Well, Alberta Health Services had a lot of promise. But in order to form it, it became internally inward-looking for the 5 or 6 years it took to form it. A province-wide accounting system, province-wide HR system, all of those things took a long time to build. While all that was going on, Alberta Health Services lost contact with its communities, with its patients, and was just seen to be a large bureaucracy working out of Edmonton, which in fact, in part, it was.
I agree with the point Chris made about this as a multi-stakeholder issue. And as I was listening to you, I'm thinking there's one powerful group you haven't discussed, and that's the general public. That's the people and the potential patients, the people in this room. Do they play a role in change in the healthcare system? Do we need to educate them? Because you always hear about the fear of the two-tiered system.
Well, that's a
great
great question. So we get the health system that we vote for. At the bottom line, this is our healthcare system. We pay for it, we use it, and I can say that, personally, I've been using it a lot recently, me and my family members, and somehow we are always hijacked by the fear of change. That's Lauren's initial question about, Canadians want change but without risk. We have to figure out ways to allow places where there can be substantial innovation in the system so we can discover better ways of delivering care for patients, and then we scale and spread those better ways of doing things. And that requires public confidence, and the public confidence has to be in the system. And I pretty much know what the current public confidence in Alberta Health Services is at this point, and has been for the last 10 years. Why would you trust Alberta Health Services to experiment with anything? Would you how many people in the room would feel comfortable if I said, we're going to develop Alberta Health Services is going to develop a new competitive model for healthcare delivery in this province? All in favor? Put up your hands. Okay, a couple of hands, but not a lot, And I think that goes back to the place for innovation. And Jack's report really talked about having a different way of looking at innovation. That's what's needed. Either whether it's within a province or nationally, there needs to be a better way of supporting innovation and the risks that come with it, because we won't get there otherwise.
Well, I'm a view that sometimes to take change, you have to work with what you got. And so you can't completely, I wouldn't want to start restructuring, for example, Alberta Health Services to do it that way.
That,
Not going through another restructuring. But what I do think is, this is why I like the concept of patient-centered care, because I think it starts changing the dialogue. And so if you start saying, okay, we need to have patient-centered care, what are the elements to achieve that? So Chris, tell me I'm wrong, because I'm not as expert as you on the medical organizational side as your experience. But first I would start really thinking like a Kaiser Permanente. How do you create, one of the things Canadians want to do is they want to maintain the idea that no one should have to go bankrupt or be put into a very bad position with the cost of healthcare. And I think everybody supports that concept, and so there's an important equity concept that you would not want to move away from. But that still doesn't prevent the idea of significant reform. And the way I would start, at least in the public system, and I became, after this year, convinced that actually, even if you created a parallel private system, it's not the full answer. You need significant change in the public system as well. And to do that with patient-centered care is I think you need to start with primary care. I think the past reports are right about that. And it does mean a very different way that you're providing funding for the medical system. Because what you do is you then fund the group, and within the group, they can figure out how they're going to compensate people within the group. This is a very different approach than what we've been doing, and it does take away from the provincial monopolies in terms of bargaining power and things like that. And then, and at the same time, you start up a portal system. You know, we've had, at the federal government has spent money on Infoway, a lot of money actually, and yet it's, all it's done is build backbones for electronic medical records. It's gone nowhere in terms of portal systems where you really need to get doctors, hospitals, and the patient's ability to look at their own records. And in fact, that should no longer be something that's excluded from them, that people are not allowed to look at their own medical records. And so you start building up this primary care system, portal system, kind of moving to a Kaiser Permanente concept. And what you do is then when you get to your gatekeeper, the gatekeeper is more focused on not just on care, acute care and things like that, but also looking at health promotion and other things that could be provided as advice. And also the use, as we've seen today, health outcomes depend more than just what you spend on healthcare, doctors and hospitals and procedures. It also depends on what people's lives are like. And that's why some of the people are now, a lot of research is now getting more focused on a wider set of issues of what determines good health outcomes, which depends on, which is focused on things like, how family, how you do in a family, the kind of stress you go through, and the kind of advice. And in fact, I'm on the board of Morneau Chappelle, and Morneau Chappelle has been doing a lot of work in health management with employers now. And in fact, one of the things they do is they're looking at the overall health record. And through the employee assistance plans, which they actually have a big share of the market in Canada, about 60%. When you phone in, when somebody is absent from work, they're immediately contacted by the employee assistance plan workers, and they're to find out why they're away. And if it's a health problem, then they will get nurses to get in touch with them right away. If it's more of a stress problem, mental problem, whatever, then it's a social worker, and then that opens up the doors for people to get help in different ways. But this is what happens when you have a broader approach to thinking about healthcare, and that's why I'm convinced that primary healthcare is a central part of getting the system into a more integrated approach, because you can also get more focused on patient care. But a big change would be in the incentive approach and how you compensate people. It's no longer done from the top, but it becomes more, you're providing bundled payments for groups, and the groups will then put together services that would provide some support. Personally, I would even go to user fees to some extent, or at least some sort of compensation. But at least if you had some private groups, then at least you can give some competition to the groups in that way. But I really think the reform of the public system will be needed, and just simply creating private option is not the solution.
Lauren talked about getting people involved in this healthcare system, and we're fortunate to have Jim Gray in the audience, and Jim has spent a lot of his private time dealing with issues of wellness and how do we actually build a citizenship that actually looks after its own health before it gets sick, before build out that wellness component. So we have to look at the demand for services, like how do we modulate the demand for service? Jack and I, we've talked a lot today about doing various things to tweak the supply of services. But we also have to look at the demand of services. And just to finish, the point about information available to the citizens, what happened to those little reports we used to get that used to say how much you had cost your healthcare system this year? You know, that to me was always a bit of a wake-up call. And when I was head of anesthesia here, I used to get phone calls from patients who would say, you know, I had this operation, but I didn't get an anesthetic. Somebody's bilking the system by billing an anesthetic here. Shouldn't have done that. You can imagine how I thought about that. But I was in Spain, and people would show up at the emergency department. Spain has a fully integrated electronic health record in Andalusia, and they would own that card. They would come to the emergency department and say, you can now access my electronic health record. It's mine. You know, the system was theirs. They had that sense of ownership. But the thing that opened that door to them was this key, this card that says, you can now access my record.
Okay. I think we're going to bring some closure to the discussion so we can open up to Q&A. But I have two questions, one for Jack and one for Chris. And for Jack, it's for both of you. What are the two first steps or the two key priorities? So we've had lots of discussion on different issues. Jack, what are the first two steps you would take to initiate change and support innovation?
Well, one step I wouldn't do is just throw more money into the system, obviously. So I think the key is to focus on patient-centered care and start building the institutions that would move us in that direction. And I totally agree with Chris on the need for ownership. Just which gets to maybe my second point. You know, people are always, you know, in Canada, the idea of having user fees is so disgusting to many people. But you know, a lot of countries use it, and I look at it as a way of helping providing some additional funding where people are going to be relieved of the catastrophic costs. But you know, you can do user fees in a very creative way, and I've written 3 papers on the subject over the past years, where you could use the income tax system, where people get a report, call it your TH form, which is all the benefits and everything that you get. You pay a tax on those benefits, but it could be subject to income limitations. Low-income people wouldn't have to pay anything, or let's say pay very little. But it already introduces a user fee concept. But it goes back to this point of ownership, and I think we need to move in that in developing these things. And the only way to force that is, I think governments, it's not a matter of money that's required. This is very obvious from this report. It's a matter of forcing the system to change, and it's going to take time because it's like a big tanker to move around.
So my 2.5 things,
Yeah.
I would definitely do something on the demand side to improve programs related to wellness, incentives for wellness, and so on. On the supply side, I would move as quickly as possible away from a system that pays for activity to one that pays for outcomes. And I would do whatever I could take to build competition into the system.
Okay, that's 2.5?
Yeah, I think that's 2.5.
Okay, so now what we'd like to do is turn it over to you, and I'm sure there's been lots of ideas bubbling up and questions that you would like to ask.
Thank you. We start off talking about how there's been reports up the yin-yang and the federal and provincial level, and it's time for action. We all know here that at the intersection of real change is usually a charismatic individual or group of people. You know, in the province of Alberta, we've got loads of people that have been hugely successful in their chosen endeavors. Who are the leaders in healthcare that you could see that could drive real change with working with the current new government? Are there those individuals out there that you see that are willing to sacrifice for the public good to bring in and execute the real change that's needed? Otherwise, I don't think we'll see it, because we can't leave it to governments.
I think it's more than one person. You know, we had an excellent leader in this province named Cy Frank, who is one of the co-authors.
Well, he unfortunately passed away during the panel proceedings.
You know, he had a vision of what healthcare could and should be that was very comprehensive. But, you know, one person alone, you know, can't do that. There needs to be a cabal of people who've accepted similar principles and lobby like crazy. You've seen, looking at what's happened with the lack of healthcare reform in Canada since the Lawn Commission report in the mid-70s, you know, this takes multiple people. One, you know, it takes a group of very, very committed people who are willing to be publicly active, who are willing to be active behind the scenes, who are willing to spend inordinate amounts of time building that citizen coalition to build a different healthcare system. And it has to be a group that is willing to run the risk of failure, and that this may be more than one generation activity to get this thing figured out. So that type of commitment and that type of leadership is hard to find, but there are people in the province who would and could do that. I know that.
Politicians respond to votes, and I agree with Chris. It's no one individual that can make change. It has to be the public itself that demands a change. I mean, think about Canada and deficits and debt in the early 90s. It was and concerns about leaving large liabilities for future generations. There was it finally the government, which that time was the Liberals, finally said, yeah, we have to do something about this. And so what happened? There was CPP reform by 1997, and there was and Paul Martin ended up balancing budgets at the federal level, and a lot of the provinces ended up doing it as well, including this one. And that's because people overwhelmingly said something's got to be done. And so the politicians actually ended up responding to what people need to do. I think we need to worry about healthcare a lot. Why? Because we have the demographic issues going against us in the future. We have actually large unfunded liabilities associated with that, because it's going to cost the working population a lot to pay for many people that are going to be needing healthcare and other kind of support in their retiring years. And so we do have a major problem coming down the road. And I think there is a chance for reform. I feel the public is getting there to saying, we need to do something. But I think it takes, groups to come to at least some concept. And that's why I like going back to the patient-centered care, because I think it's something that people can rally around as a concept. And maybe that's what we need to do, is to force change. But any single report is not going to do it. You need a broad part of the population to say and demand changes to the current system.
When a prime minister comes in or a new premier comes in, he writes directive letters to the new ministers. And the one to the new health minister was publicly available last week. The first item talks about having a new health accord starting from funding, starting on a funding agreement with the provinces, and then doing things that are kind of right in terms of looking at pharmacare and mental health and so on. But it's not the mandate. It's the same old federal, provincial, thing replayed again. It doesn't have that big vision. So for a new government, there's a period of time where you could influence the federal Liberals to be more aggressive in what they're asking from the healthcare system, because coming up with a new health accord sounds like Paul Martin's ear all over again to me.
And when they get into budget making, they're going to find it gets tough, because if you throw more money into the healthcare side, then there's less money available for other things, or you got to start raising taxes even more on the population. And there is only so far you can to hit the corporations and high-income people when you have to look at a broad-based tax.
Okay, I think there's a question out here. Okay.
There's lots of stories about successful pilots and that type of thing dying in the restructuring pendulum, where we're going from re-centralization to decentralization. If this is fundamentally a change management issue, could you comment on delayering rather than restructuring? It seems like the more layers you have between the providers and the thinkers, the less happens. You've got basically change resistance in every layer.
Yeah, that's the rub, isn't it? So you build a really complex system, you need a lot of management to run it. You try and get rid of the management, and you find that some decisions get sped up, some things just don't work. I think that we have lost a lot when we moved away from regional health authorities. The regional health authorities weren't being held accountable in the way that they should have done for dollars and for some of the programs they were doing, but they were more to the scale where people could understand them and influence them. And the issues that were happening with the health authorities a decade ago were really around accountability. How do you hold a health authority accountable? And that's a governance issue, and I think that could have been dealt with differently than just destroying the health authorities at that point in time. As you build the larger bureaucracy, the effectiveness always becomes a problem. I looked at the number of layers that we had in our organization and in Alberta Health Services, and there were a lot of them. And, with Steve Lockwood looked at getting rid of some of those layers. And everybody has the same ideas. It takes time to do that. But I think that the complexity of health really puts you in a difficult situation in terms of keeping that citizen accountability, the ability of a citizen in a local health delivery unit to move forward and change, and yet be accountable, for 40% of the provincial budget at the same time. There's a real paradox in that. And it is a difficult thing to manage, but I don't think we ever hit the sweet spot in terms of having the right number of management layers and the ability of people to actually get things done in their areas. You hear about, I used to get letters by the day about how ineffective and how resistant the local people were finding the bureaucracy to deal with. And it was one of the things that just really, really bothered me a lot, and still does, as you can tell.
Just very quickly, I think if you go back to the concept of primary care and create a bunch of groups, then it can allow you actually to have a very different way of how you administer the system. And so to me, it's not the layering that you start with. It's where you're trying to get to in the first place in terms of how you want to organize the system.
You've described the impediments to change rather well. I understand that our neighbor to the east, Saskatchewan, is using the lean concepts as a way to drive change in their healthcare system. Do you have any sense of how that's going? How did they manage to embark on such seemingly dramatic change?
Well, I think there's some strength that comes from choosing one thing and doing it. It's basically choose, decide, and do it. Don't just do things by half measure. And what's happened is they have made improvements because of the use of lean, but they've started a cultural change. Where people think they can change the system, where they can get rid of unnecessary layers, where they can take parts out of processes. And so all of a sudden you have frontline staff who feel fully empowered to do things and confident that they can. So is lean the right thing? I don't know. I don't care. But it's that sense of, we'll do it and we'll get it done and we'll go on and we'll do the next thing.
So some of the most effective changes I've seen in the business sector has been kind of like doing what Saskatchewan's doing in a way, and that is you come out with a goal and then you ask your employees, how can we get there? And in fact, that's actually not a bad way to proceeding, I think, in the case of healthcare, which part of the problem is actually getting people on side and not blocking change. And so that's why I don't think it could be completely top down. I think you need to engage people, but if you kind of describe, here's where we need to get to, and ask me, and does this make sense? And I think most people would say yes, because they're kind of sensible goals. Then you can then start saying, okay, give me the ideas about how to get there. And I've seen quite dramatic change happen in organizations when they follow through with that kind of process.
Okay, I think we have a question over here.
So politicians are motivated by and work within 4-year cycles. So Chris, you talked about the restructuring within AHS over the past decades, and that's been driven by politicians. I mean, different ministers, different premiers have decided to be seen to be doing something by restructuring, but not actually reforming. So my question is this, the magnitude of the change, and I'm going to speak specifically about Alberta, and the will to create that change requires longer than a 4-year cycle. So how do we get that political will? How do we create that desire within government, because they control the system, to really do some of the things that you're talking about?
It's a complicated question, obviously. I mean, people have talked about having a crown agency for health, but if you were the premier responsible for giving 40 cents on every dollar to the healthcare system, how independent would you like it to be? And the answer is not, I think. What you would not change is if there was a strong sense of positive movement in a direction on healthcare reform that the public was supporting, that would be politically difficult to change. So going back to the earlier conversation about having citizen leadership of a change in the healthcare system, of having a group of leaders who get together and sort of can bring that public together to support an ongoing platform, becomes very difficult to change once you have that level of public support. And I think the politicians change the direction of the healthcare system frequently because no one in the public really has too much confidence about the direction it's currently under. If you can build a more broad-based public support for a direction, I don't think it will change that much. But if you can't build that support, it will just get buffeted in the wind as you see right now.
No, it's just, I think, I don't have too much to add to what Chris said, but yes, you know, we always talk about the short-term political cycle and how hard it is to get change. But again, it goes back to my point that if the public really demands a change, it doesn't matter who's in government, they're going to have to respond. Otherwise, they're going to be out. And of course, one good thing about the Canadian system, because we don't have term limits for governments, they do like to get re-elected. And so, you know, if the demand from the public is this has got to change, the system's got to change, and here's what we're looking for, then I think you'll find change will occur. Even the next party that takes over will have to move in the same direction.